One. Are these people going to
People are already joining in.
Yes.
Can push that.
Yeah.
So, leave.
Kapata Urban Clinic. Oh.
Those who have not muted their mics, please, we are getting what you are saying. I don't know if it's
But for us, I think at the back it's nice. Hola, Kashka. This time, young man, how are you?
I don't get the sound. See.
Sono sbagliato. La luce che fai?
We have 72. Good afternoon, everyone. We want to thank you for your diligence in joining us at 5 o'clock today. Just before we start the session, we just want to do a quick sound check and visual. Please wave if you can hear me very clearly. Thank you so much. I want to introduce the people that we have here. As you may be aware, we are in the middle of the COVID-19 pandemic. Joining us today are our colleagues from the private clinics in Lusaka, but you will note that the network is bigger because we also have people from our usual facilities. We want to welcome you, especially for those who are joining us for the first time. If you are having a problem with either your sound or your visual, please, you can type in the chat box and you'll be assisted by our IT. So we welcome CFB, we welcome PHI Family Clinic and all the rest of the clinics. Our expert for today is Dr. Francis Mupeta. He's an infectious disease physician. On the panel, he is joined by Dr. Surilani Sibile, Professor Lloyd Mulenga, Ministry of Health. From ZNPHI, we have Dr. Paul Zulu. We are also going to be joined by Dr. Nyambe. We are also expecting to be joined by people from our virology lab. So I'll go into a brief. Oh, and obviously Jonas Hines, because we've never met, but we work together. So, and we are joined by our colleagues from CDC who are working together within this pandemic. And thank God we have Duncan who has also joined the team. So we have really the key people that are managing this pandemic and are here to assist us answer our questions. Of course, we know that in late December 2019, a pneumonia of unknown cause was detected in Wuhan, China, which was eventually found to be caused by the COVID-19. The genetic sequence has been shared with the rest of the world, so people are able to sequence it. On the 30th of January 2020, COVID-19 was declared a public health emergency of international concern. By the 11th of March, it had escalated and had been declared a pandemic. In short, we have more cases than expected in a population, and now it is global. As of today, 18th March 2020, we'll find out what is going on in Zambia and how we are responding to this pandemic. Dr. Francis Mupeta, go ahead.
All right. Good afternoon, people on the network, and good afternoon, people in the hub. Indeed, it's a great honor to be invited to speak on the COVID-19 pandemic. As we know, And we heard from our Minister of Health that indeed the pandemic has actually reached our country, Zambia. And we'll talk a bit about what's happening with regards to the confirmed 2 cases, who happens to be a couple. And they are actually Zambian residents. And we're going to do, we can have the slides now. Okay, so I know there are certain people who are saying you are muted. Yes, you'll be given a chance to ask. What you have to do is click on the participants, and then there's a hand sign there. And then you can click on that, and we'll be able to see that you have raised your hand if you have got any question. That is for those who are not very familiar with the platform, the ECHO platform. Okay.
If we're a bit slow, our usual venue has just been taken by an urgent meeting, so we've had to move.
Okay, so I've got no disclosures to make. So the objectives of this presentation really is to understand the epidemiology of COVID-19 and also to discuss the clinical manifestations and to discuss exactly what are we supposed to do if you encounter a suspected case, and to recognize the preparedness and response structures that we need to combat COVID-19. We thank our partners who have greatly contributed. So the content is outlined, is as outlined. I'm afraid that the pause, are we able to project the pause? No. All right, so we are not able to project the pause, so we'll come back to them later. So I am going to talk about the overview and epidemiology of COVID-19. So a little bit of background to the coronaviruses. So we know that coronaviruses is a large family of RNA viruses, which actually cause respiratory illnesses, both in animals and in humans. They are ubiquitous in the environment, meaning they are found everywhere, and they circulate among animals and humans as zoonotic viruses. So far, we know that there are 7 coronaviruses that are known to infect humans. And the spectrum of diseases they cause actually ranges from a common cold, which is caused by, among the 84 species, in about 5 to 10% of all acute respiratory tract infections in children, and up to about 30% of common colds, 10% in children, and up to 30% common colds in children being caused by coronaviruses. So the severe illnesses, so far what we know is that there have been 2 species which are known to cause severe illnesses. That is the SARS-CoV of 2002, whose case fatality was approximately 10%, and then the MERS-CoV 2012, whose case fatality was quite high at about 30%. So what about the 2019 pandemic? This one is being caused by the 7th species now, which we are saying it's a novel coronavirus, meaning it was previously unknown. So this virus is called SARS-CoV-2, all right? And the disease that it's causing is what is known as coronavirus disease 2019, or in short, COVID-19. So COVID-19 was first reported in city called Wuhan in China, Hubei province, in December 2019. Initially, it was linked to a certain highly congested sea animal market in China where people buy live animals as well. So it was thought that the initial cases were likely animal to human spreads of a known species, but because of the genetic makeup of SARS-CoV-2, it has been linked to, it's very closely related to a coronavirus found in bats. So it's, for now, we are postulating that the intermediate host should be actually bats. But now we know that there's widespread person-to-person transmission in China, and also community transmission, which is occurring now outside China, including Europe, which has now become the new epicenter, especially in countries like Italy, and then Iran, Japan, South Korea, including the United States now has got some community transmission. So we know that the dynamics of COVID epidemiology at the moment is very dynamic, and we are seeing that the initial epicenter, like China, actually the cases now they are having are more of imported cases, meaning there are very few community transmission which are happening in China. So as of today, we know that there are over 200,000 confirmed cases worldwide. And we can see that the dotted maps there, the red dots on the map is indicating the number of cases which have been reported. This was actually about a week ago. We know that now we have the latest countries reporting, especially in Africa, like a country like ours, Zambia, which happens to be the latest country to have reported as of today. So initially, many cases were linked to China, like I've said. But we know that now the hotspots have changed and seems to be Italy, the US, and Asia. Okay, I'll pause for now so that we give chance to the peers to open.
Okay, good afternoon, everyone. Once again, we have the privilege of being joined by our permanent Secretary, Technical Services, Dr. Kennedy Malama. We would like him to officially open our session, which is a privilege for us. This is a very important session, and we would like to welcome you.
Which one is he using? He's using his.
Yes, Malama, please go ahead and speak. Oh, he's over there.
Where?
He came out.
Where does Macau? Keep moving against the people.
Scroll down, please. He will keep moving. Okay. He's over here. Dr. Malama, the floor is yours.
Thank you very much. Are you getting me?
Yes,
we are here. Very well,
thank you. Thank you very much. And I know, Dr. Mupeta, sorry for cutting you short. You were presenting very well. But let me take this opportunity to commend all of you who are part of this Zoom orientation, and to put it on record that this is a difficult time for us as a country, but more importantly as the health sector. At this point is just to thank all health workers in our country who continue to do their best. And we are cognizant of the various challenges health workers face while delivering healthcare services. Today, it's a day that health workers, we need to work as a collective and ensure that, number one, we take care of the carers. Health workers, always when you have an outbreak, always when you have a public health threat, they get the highest risk. So whatever we do, whatever interventions we put in place, we need to ensure that health workers are given the comfort, the assurance, and the support so that as they deliver healthcare services, they are also protected and supported adequately. As you are aware, one of our key pillars as Zambia is health security. This threat, this outbreak of COVID-19 with 2 cases confirmed in Zambia is reminding us once again that we can only prevent public health threats and emergencies by investing smartly in health security. And this orientation or discussion you're having this afternoon is reminding us why we should not negate on strengthening health systems as a country. Dr. Mupeta was just referring to the numbers, which are quite alarming. We are all aware globally now, as at 16 hours, 35 minutes, 200,533 cases globally have been confirmed with 8,165 deaths. When you come to Africa, we are talking about 562 cases with 16 deaths. Zambia now, we are talking of 2 confirmed cases, of course, no deaths. So what this means is that this is an evolving outbreak or pandemic, and Africa, which initially was silent, has been engulfed. So what does that mean for Zambia? For Zambia, it means we need to upscale our interventions. And for us as a country, it doesn't matter whether you are in a private sector, you are in the public sector, you are in the community. This is the time to work as a collective, to forge together. For my colleagues in the private sector, it's just to remind you that the risk can even be higher in the private sector, because if you see, almost all the cases in Africa have been imported, including in Zambia. The 2 confirmed cases, we see that there is history of travel from outside the country. And already from the alerts we've tracked, we've noted that people have tended also to go to the private hospitals in our country because of the class they belong to. So there is no health facility which should relax. We all need to ensure that we up our game. Key points are: 1, to ensure that our preparedness levels are upscaled. We also need to ensure that this activity we are doing of capacity building is scaled up or rolled out to all parts of the country. This morning, I was talking to the team in one of our rural provinces. They also have an alert. So there's no part of the country which should consider itself. People travel. I can come out from outside the country today, and in the next few hours, I'm in the remotest parts of this country. So in terms of preparedness, we need to ensure that capacity building interventions are scaled up. We give you the comfort that as headquarters, we are looking at how we can preposition as many supplies as possible, including PPEs, to all the strategic places in our provinces. We would also want to urge you that number 1 is to ensure that infection prevention and control interventions are heightened. As I mentioned, healthcare workers, before we even think of a patient coming, I always say healthcare workers are at risk. So within our infection prevention control measures, let's ensure that we put a health worker at the center. It doesn't matter, it's a student, it's a consultant, it's the junior most in the healthcare facility, they are all part of the team. We also need to ensure that the various guidelines we've provided, these guidelines are evolving. Tomorrow we may tweak them depending on the evidence coming. So let's ensure that everyone in our team, they are conversant with the protocols and the guidelines we've provided. We also urge all of you to have a high index of suspicion. This is the day, this is the time you should be very suspicious. It could be a patient you are already treating in ICU. It could be a patient already you are treating in maternity wards. Be suspicious when you see something unusual or fitting into the case definition. You are correct to trigger the processes and ensure that if that is the case, the good is done in that particular patient. So let's ensure that we heighten our level of suspicion. Index of suspicion should be at its maximum. As Ministry of Health, we are working as a collective with all stakeholders. This is the time to blend. For the private sector, our private hospitals and facilities, we urge you, as you've shown a lot of commitment so far, to blend in work with the Ministry of Health and our National Public Health Institute. This is not a time to disaggregate or to say where you belong and where you don't belong. We are all one. At the end of the day, we would want to protect the health and well-being of our people. Lastly, is to ensure that case management is not neglected. Case management is not neglected. There is no cure yet for COVID-19. There is no vaccine yet. All this is emerging story. I know most of us are always ahead. You are checking online what is happening, some of the drugs which have been mentioned, and they can be used. But for us is to remain focused and ensure that at the right time, through our guidelines, we shall inform you how as a country we shall proceed, and of course guided by the World Health Organization. So with those few words, once again, I would like to commend all of you who have zoomed in this afternoon. It also shows that you are committed and you are worried that as Zambia, can we make the 2 confirmed cases as the start and the end, so that now we start counting days so that we don't see any more confirmed cases as a country, because that's the situation we want to be. Remember, any outbreak which comes, it disrupts your routine services. Already when we look back some days from today, we shall pick up some losses we would have incurred as a health sector, because certain things we should have done, definitely we are not going to do them. So Professor Mulenga, Dr. Mupeta, and everyone else, once again, it's just to thank all of you, wishing you the best. In our engagement at national level, we have a broader picture. We are looking at all the 10 provinces, but of course, prioritizing the areas of focus as we move. So I wish you the best as you continue, and I'm sure as a collective, we can mount an effective response and roll back COVID-19. Thank you very much.
Thank you so much, Dr. Malama, for alerting us, and we really appreciate your commitment to fighting this outbreak. Please go ahead.
Thank you very much. And I think the PS in the nutshell has given almost the entire presentation. Yeah, but nonetheless, we'll try to. Thank you very much.
Thank you. Thank you.
We'll still try to go through the slides. Yes, Mr. Kote, yeah. So we were talking about Zambia, and I think the PS has just confirmed already what was announced by the minister. So as of today, we have 2 confirmed cases in Zambia. And a few details that this is a couple that traveled as a family with children and returned to Zambia on the 15th, which was on Sunday. And then through the efforts of the surveillance system, they were actually identified from the airport and put in self-quarantine while awaiting for the test. And when we got the test results, they were actually taken to the quarantine facility here in Lusaka. So ZNPHI definitely is leading the preparedness efforts, and they have heightened the screening at points of entry, including the border posts and the international airports. Then there's also monitoring of persons with respiratory symptoms and fever, and then training of first responders, of which we have trained close to 500. And then testing samples, of course, which is being done here in the capital, and procurement of commodities which are needed. All right, so epidemiology, we know that transmission of COVID-19 is through close contact. This is when an infected person releases respiratory droplets, which could either be by coughing or sneezing, and then these are actually released in the environment. The droplets can travel up to maximum of 2 meters from an infected person, although interventions such as high flow oxygen or during intubation and any other maneuvers that happens in the hospital can result in projectiles traveling longer distances than 2 meters. Transmission can also occur from contact of surfaces and fomites, And we know that the aerosols actually can remain suspended in air for up to close to an hour. And then certain surfaces like copper, aluminium, the virus can actually survive up to 9 hours if there is no cleaning that has taken place. The virus has also been isolated in stool, but whether this can lead to transmission is yet to be kind of established. In China, where the epicenter was initially we know that transmission was happening in family clusters. And then primarily the disease is targeting adults, especially the elderly, the median age being 51 years old. And we know that about 80% of the people who are affected by COVID are above the age of 30, between 30 and 69. Very few children are being infected, both in China and now in Europe, which happens to be the new epicenter. So let's look at a close contact. Who is a close contact? Two authorities have actually, identified this differently. If you look at WHO, a close contact is one who is caring for or visiting a patient in a healthcare setting without personal protective equipment, or one who is working or attending school together in close proximity with a confirmed case, or living in the same household or traveling together within a distance of 1 meter, of which we know that transport mediums such as buses or aircraft provides such kind of, someone being a contact. And then the CDC from US defines a contact as one who is being approximately being 2 meters from for a prolonged period of time while not wearing PPEs. And then having direct contact with an infectious secretions such as being coughed on while not wearing PPE is also defined as a close contact. Please click on this slide. Okay, so the incubation period is anything from 2 to 14 days, that's the range, but what we know is that the proper one is about 3 to 6. Then there's also delayed onset of shortness of breath by about 5 to 8 days after the commencement of symptoms. And then most infections, about 80% are mild or moderate. The recovery period is about 2 weeks for those with mild symptoms, and then severe can take anything from 3 to 6 weeks. And mortality is actually pegged at 1 to 3%. We know that the symptoms actually are non-specific, just like most viral infection, but mainly there is fever and a cough, which are occurring in almost 80% of the patients. And we know that many other illnesses can actually present with these constitutional symptoms. Asymptomatic infection is there and appears to be quite rare in less than a percentage of people. And then 75% of these asymptomatic infections at diagnosis actually progresses to become symptomatic illness later on. It's difficult to know whether the asymptomatic disease would actually present with negative tests, but we know that some of the asymptomatic clusters have known or have been said to transmit, especially in family clusters from reports in China and Hong Kong. Viral shedding is greatest early in the disease and normally can occur about a day or two prior to symptoms onset. So meaning this would be asymptomatic. Patients would actually be shedding the virus and result in transmission. Then shedding of the virus can also occur 7 to 12 days in mild and moderate disease, and sometimes longer to more than 2 weeks in patients who have severe disease. Then PCR can remain positive after somebody has become asymptomatic. Whether this results in significant transmission or not is yet to establish, as we know that this is a new disease. So the clinical symptom features are actually varied, and like we have said, the majority of cases will be asymptomatic. But we know that severe illness actually can occur in about 15 to 20%, and mortality in about 1 to 3%. So both of these stats are actually somehow an overestimate, especially if we look at results which are coming from China. We know that so far countries in Europe are reporting somehow different stats from what has been observed in China. So it will be interesting to look at the global picture when we put all these results or studies together. Severe illness and death is more common among the elderly patients and those with chronic medical condition, especially those with heart disease, hypertension, lung disease, kidney, diabetes, and immunocompromised states, especially those with malignancies. In China, we know that the population of patients with HIV and AIDS is quite low. So we are yet to know how exactly this disease behaves in conditions such as HIV and AIDS. But we'll talk about that later on in the presentation. So like I said, a thorough history and high index of suspicion are very important. And we know that the PS emphasized this. As we have reported 2 cases already confirmed, we need to maintain a high index of suspicion. And this definitely, we should suspect anyone who is coming with symptoms such as fever, which we know occurs in up to 98% of patients with COVID, a cough occurring in up to 82%, shortness of breath or dyspnea in about half of the patients, myalgia and fatigue in close to 44%, and then others can present with sore throat, diarrhea, which is not quite common in about 20%, and then nausea in 5%. Shortness of breath is normally not a prominent feature at presentation, but tends to develop, especially around the 8 to 10 after the onset of symptoms. In terms of investigations, the common lab investigations is that on full blood count, we actually see there is preponderance for a lymphopenia, which is low lymphocyte count, then elevated enzymes, especially AST and ALT. Then you can also get leukocytosis, but mostly you get leukopenia. And then normal procalcitonin levels, which is a marker of bacterial infection. Then radiographic findings, actually we have seen bilateral lung involvement on chest X-ray. As you can see, it will look like an X-ray which is projected there. And if you are not having a high index of suspicion, you can actually label it as medial TB or TB, whatever we may think of. So it's always important that we differentiate COVID-19 with the commonest presentation that we are accustomed to, which is TB. So we should familiarize ourselves with the type of radiological patterns. So,
at this point, we'll take a few questions, but before we do that, we'll pose a few polling questions. As you may be aware, we are using our sub-hub, not our main hub, so we are having a bit of back and forth. So we'll go into our poll. For those that may have not used this function, you'll be able to vote. Of course, we can't know what answer you've given us, but you'll be able to vote and we can discuss this later.
Somebody else.
She's not doing that.
She's not being sure.
Okay, we'll take a few questions at this point.
Okay, any questions at this point?
So we have something in the chat. Please remember that you can go to participants and then raise your hand. There's an icon there, but there's something in the chat. They're saying, please go down. They were asking if the kits are available for testing people. Are the kits available?
Okay, so we have the testing kits, but like we know, and like the rest of the world, we cannot just go about testing everyone. So that's why we are saying there has to be a high index of suspicion, and then definitely the patient, the suspected person should actually meet the case definition, which we are going to talk about later on.
Okay, do we have any answer?
I think issues of treatment, which the PS talked about, that there's no cure. We are going to address also the aspect of treatment later on, and I'll explain further with regards to what has been circulating.
Okay, if we have anyone with a question, they can please unmute themselves.
Most of them won't be able.
Okay, you go to participants and there's raise your hand icon, but there's a question here. Please, let's go up. Please confirm that we are using the technical fever of 37 rather than the significant fever of 38. This is from Dr. Welsh to everyone.
Just open our.
Okay.
You can answer.
Okay. This one I think can be answered later because we have something on PPE. And then there was a question on the chest X-ray. What is the classical chest X-ray features of COVID-19? It's ground glass. And we have somebody asking Dr. Nalwea, what are the effects of COVID in pregnant women? Are they more susceptible? Should we expect an increase in preterm delivery, IFDs, neonatal respiratory distress syndrome because of the virus? Of all cases reported, how many were pregnant?
Okay, so thank you very much. I will start with the fever definition. Of course, we are using 38 degrees.